The minimally functional patient. Returning now to the example of Mrs. Smith, we find her to fall squarely between the permanently vegetative and the moderately functional patient. Like the totally non-functional vegetative patient that was Mrs. Jones, Mrs. Smith is so demented that she lacks most of the criteria of moral personhood. Unfortunately, she appears to have been reduced to a mere shell of her former self. She can no longer reason, communicate, except in the most rudimentary, reflexive manner, relate to her family, or experience manifestations of love. Indeed, it is doubtful that she can be accurately described as a self-conscious moral agent whose identity through time is cemented by the bonds of memory. There is, in cases such as this, where the psychological glue of memory has given out, simply no enduring self there. Formerly a self-conscious moral agent with a well-defined idea of the good, hopes and plans for the future, Mrs. Smith has been reduced to a mere locus of transient sensations. That is, she's just a location where they come and go. As philosopher James Rachels puts it, she continues to have a biological life, but her biographical life has come to an end. On the other hand, Mrs. Smith resembles Mr. Black, at least in her possession of some conscious life. Okay, so recall from the chapter on the mind what conscious experience is. That's what we're talking about here. So she possesses some conscious life, albeit on a very low level, and in her ability to experience pleasure, pain, and perhaps some rudimentary emotions. Although she is not a person in the strict sense, she does have some interests. Insofar as she is open to pleasure and pain, she has a definite interest in experiencing the former and avoiding the latter. How might a best interest test be applied to someone like Mrs. Smith? In order to justify the termination of food and fluids under a best interest test, decision makers would have to show that the burdens of a patient's life with the proposed treatment would clearly and markedly outweigh whatever benefits she might derive from continued life. In other words, they would have to show that the patient would be better off dead. The most influential formulation of this best interest test, the majority opinion in the Conroy case, requires not merely that the burdens of life clearly outweigh the benefits, but also that further treatment would be inhumane due to the presence of severe and uncontrollable pain. All right, so this is the reading guide. On pages 941 and 942, Arras discusses some parts of the court's decision in the matter of Claire C. Conroy from 1985. You don't really need to know anything about that case other than what Arras says. The woman, Claire Conroy, was in a state similar to Mrs. Smith, but she died before the case had finished being decided. Okay, and I think in this case, so one party, maybe a nephew, wanted to stop life-sustaining treatment, and then maybe her doctor didn't want to stop it, so that's why it ended up in court. So that case was decided by a panel of judges. I'm not sure how many, 3 or 5 probably. And so the majority opinion in the Conroy case defined a specific formula for best interest tests. So that's what we're going to use here. The court's motivation in establishing such a strict standard is not hard to grasp. While people might disagree about the desirability of persisting in a minimally functional condition, severe and intractable pain is presumably something that just about everyone would prefer to avoid. It is this nearly universal sentiment that death would be preferable to a life of unmitigated pain and suffering that gives this test an air of quote-unquote objectivity, as opposed to the subjectivity of tests based on the patient's past preferences. How then would the strict formula apply to Mrs. Smith? As we have seen, there isn't much to place in the benefits column. No longer able to take food by mouth or to interact meaningfully with her family and caregivers, it appears that Mrs. Smith experiences few pleasures apart from an occasional rub or combing. The only possible benefit to be derived from further treatment would appear to be the indefinite continuation of this twilight existence. And although the patient might conceivably derive some pleasure merely from lying in bed and dwelling in her alien world, it is highly doubtful that such a patient, bereft of memory, a sense of continuing selfhood, hopes and plans, that is, lacking all of these things, could possibly have an interest in or be benefited by continued existence. Given Mrs. Smith's low level of existence, it is equally difficult to discern the burdens of continued treatment. To be sure, she will experience some degree of pain and discomfort from the surgical insertion of a G-tube, but this pain will not approximate the kind of prolonged, severe, and intractable pain required by the Conroy best interest formula. Another possible source of pain and suffering would be the forcible imposition of medical treatment against the wishes of the incompetent patient. Even incompetent patients can have strong preferences for or against treatment or diagnostic procedures, and even if these preferences are not well grounded in medical reality or in the patient's previously authentic value system, forcible treatment will often be experienced as a painful and humiliating violation. Although this kind of coercion need not be thought of as a violation of the patient's autonomy, which may have already been destroyed by dementia, the pain, humiliation, distrust, and hostility it engenders must nevertheless be counted in any best interest calculation. Okay, so just quickly, autonomy is a kind of freedom. It's not political freedom, but it's the freedom that a person has when they are able to make choices that are in their best interests. So a person might not always make choices that are in their best interest. They might sometimes choose to act in someone else's best interests, but they're at least capable of making choices that are the right choices for themselves. If at least some of the time you're capable of thinking about what's best for you and then acting on that, then you're an autonomous being, an autonomous agent. Okay, but in any case, someone like Mrs. Smith has no autonomy. She clearly can't, make choices or act on her choices, but even beyond that, she can't even, in principle, think about what's in her best interests. She doesn't have any of those capacities. But nevertheless, even lacking autonomy, it's still the case that the pain, humiliation, distrust, and hostility that treatment may cause must nevertheless be counted in any best interest calculation. In some cases, Mr. Black's, for example, the negative consequences of forcing treatment may not be worth the gains. In Mrs. Smith's case, however, the side effects of coercive treatment are likely to be non-existent. As we have already seen, her aversive reaction to the nasogastric tube feeding could just as easily be ascribed to immediate physical discomfort as to some deep-seated desire to die through the refusal of life-sustaining treatment. Mrs. Smith is probably too demented at this point to have preferences about tube feedings or to acknowledge the forcible imposition of surgery over and against her aversive behavior. It is highly unlikely, then, that she would experience the insertion of a G-tube as a violation of her wishes, no matter how distorted those might be, or as a painful humiliation. In the absence of any persistent and severe pain underlying her condition, it would appear highly doubtful that the burdens of Mrs. Smith's continued existence clearly and markedly outweigh the benefits, even when the benefits approach zero. A literal reading and application of the Conroy formula, the Conroy best interest formula, would thus lead to the conclusion that the G-tube should be surgically implanted and she should be maintained indefinitely with artificial nutrition and hydration. Okay, so quickly, just to review this. So I didn't actually make a note here in the margin, but in this second column on 941, we're going through the benefits and the burdens. So right here, this is the one benefit of continued existence, of receiving the life-sustaining treatment. Right here, Arras is saying this does not count as a benefit. And then here he is saying that this is not a burden. And then similarly, again down here, he's saying that this is also not a burden. So we've been through everything, and then here is the calculation. It appears highly doubtful that the burdens of Mrs. Smith's continued existence clearly and markedly outweigh the benefits, even when the benefits approach zero. Okay, and then, so this is the decision that we end up with. Limitations of the best interest standard. Not everyone will be satisfied with this result. Those who believe that quality of life should never affect treatment decisions will no doubt applaud this conclusion, but others might well think that something important has been left out of our deliberations. Judge Handler, the lone dissenter in the Conroy case, identifies this missing factor as a legitimate concern for the patient's probable feelings about broader issues such as privacy, dependency, dignity, and bodily integrity. Okay, so as I said on the previous page, the Conroy case was decided by a panel of judges. I'm not sure if it was 3 or 5, but the majority decided that the best interest test that we were talking about on the previous page is how we should make decisions in these kinds of cases. Judge Handler disagreed, so she was not part of the majority when they voted on the case. And one point she made was that these factors are being left out of a best interest test like the one we talked about on the previous page. Okay, so by focusing the entire best interest discussion upon the narrow issue of pain, we tend to reduce the patient from the full-fledged person that she once was to the status of a mere physical repository of pleasures and pains. Is this crudely hedonistic notion of the good an adequate or desirable measure of humane treatment decisions for minimally functional patients? All right, so is this crudely hedonistic notion of the good an adequate or desirable measure of humane treatment decisions for minimally functional patients? Should we simply ignore the patient's probable responses to such abject dependency and daily violations of dignity? Although Judge Handler's dissent eloquently pinpoints a major shortcoming of the Conroy best interest formula, it is problematical in its own right. Specifically, it is unclear how Judge Handler's concern for these larger issues of privacy and dignity might be grafted onto the Conroy best interest formula. That test, let us recall, attempts to ascertain the present best interests of patients. It asks about the present and future benefits and burdens likely to be experienced by the patient. The obvious problem for Judge Handler's proposed enlargement of this formula is that severely demented, minimally functional patients like Mrs. Smith are presently incapable of experiencing what more functional patients would describe as insults to their privacy, dignity, and physical integrity. Although it is quite possible that the formally competent Mrs. Smith say, 10 years before she ended up in her present state, would have been appalled by the loss of dignity entailed by her present situation. The present Mrs. Smith knows nothing of dignitary insults or violations of privacy. She is so demented that she cannot be affected one way or the other by solicitude for her present responses to these larger humanistic issues. All right, there's the sentence. Okay, solicitude means care, or maybe even care in the sense of being worried about. So Mrs. Smith is not in a position to be affected by anyone's cares or worries for how she might presently respond to violations of her privacy or dignity. In order to vindicate Judge Handler's concerns, we will have to reintroduce them at the stage of our inquiry into the patient's prior preferences, that is, the substituted judgment test. Okay, so that's the method for determining whether or not we should continue the treatment based on what we think the patient wants. So that was what we talked about in the beginning of the article. Under that test, we would have to show that Mrs. Smith would have clearly viewed continued treatment under these circumstances as an indignity, and that she would have preferred an early death to the insertion of a G-tube. The problem with this move is that, as we have already seen, Mrs. Smith left behind neither a precise advance directive nor a pattern of analogous choices that clearly demonstrate what she would have wanted under present circumstances. Indeed, our earlier failure to provide this sort of clear evidence mandated our present effort to find a solution in terms of Mrs. Smith's best interests. Okay, so earlier, at the beginning of the article, we tried to determine what the correct treatment decision would be based on subjectively what we thought Mrs. Smith would want. We found that those methods run into problems, and so that's what led us to try to find a solution in terms of best interests. Okay, but now we have come full circle. Our inability to satisfy a rigorous substituted judgment test, that is, trying to figure out what the patient wants, required us to search for a solution in terms of Mrs. Smith's best interests. But the best interest test, at least as articulated in Conroy, led to an unacceptably narrow focus on pain that excluded important values. Okay, so what Arras is saying is this kind of calculation that we talked about here, and that, as he acknowledged, might satisfy some people who believe that quality of life should not affect treatment decisions. So some people might be satisfied with this calculation, but he's saying over here that that kind of calculation leads to an unacceptably narrow focus on pain, and it excludes important values. That is, these values here: privacy, dependency, dignity, and bodily integrity. Mrs. Smith's present lack of capacity to appreciate such values finally led us back again to the substituted judgment test. Clearly, something has gone wrong here.